Good morning. I'm Dr. Meredith Warner of Warner Orthopedics and Wellness and the Well Theory. And today we're going to continue our monthly free education of the public mostly because I'm related to a lot of teachers, so I sort of just can't help myself. Today I want to talk about diabetic neuropathy sort of in general, but really kind of focusing on diabetic neuropathy and then some treatment options and sort of where we are in the field, if you will. It's a very common problem. I'm sure some of you out there listening have it, or you know somebody that does have it, or you're worried you're going to get it. We're going to just kind of go into it and tell you what to worry about and not to worry about and what you can do for yourself. Simone, Sally. Good morning, Simone and Sally. And Jessica. Thank you. All right. Thank you all for spending your Sunday morning learning about neuropathy. That's me. I teach for LSU, and I also have my private practice in Baton Rouge. And then the Well Theory is sort of my passion and love of natural medicine. All right. This is our clinic in Baton Rouge. Oh, sorry. This is our clinic in Baton Rouge where I treat neuropathic pain often. We see a lot of diabetics, something like, 40% of the Louisiana population is either pre-diabetic or diabetic, believe it or not. So I see a tremendous number of people with nerve pain, neuropathic pain, unexplained symptoms, and then of course, diabetic wounds and all of the foot deformity and fracture problems we see with what's called neuroarthropathy or neuropathic damage to the sensory nerves that go to the bone, which allow repeated trauma to sort of get worse and worse and worse. So what is neuropathy and what is diabetic neuropathy? And why does it even matter? Well, really it matters because it impacts quality of life to a massive degree. So we're going to talk about that a little bit. We'll talk about how nerves work a little bit. We've talked about that more extensively in other talks. Some treatment options. So there's surgical options, there's non-surgical options. Obviously, I do both because I'm a surgeon. Non-surgical is traditionally the vast majority of people in how they're treated, but surgical options are starting to show a lot more promise, and probably we should be a bit more aggressive in how we indicate to treat neuropathy surgically, and I'll explain what I'm talking about later. There's some minimally invasive surgical options, some less minimally invasive ones, and then of course, natural treatments, which are always the best, if at all possible, to include prevention. And of course, that's going to include diet, lifestyle, and supplements. So these are people that feel shock. You feel really cold or painfully cold. There's tingling or electrical sensations or like ants crawling under your skin, burning pain. I hear that a lot. Pins and needles. These are the kind of words I hear of people that have diabetic neuropathy with pain. Now, remember, some people can be neuropathic and have no ability to sense and no normal nerve function, but they may not have pain. Some people are unfortunate and have both, and that's about 50% of neuropaths. Excuse me. All right, so there is a marked decline in quality of life, and in all of our literature, that's always abbreviated QOL. So a decline in quality of life across multiple domains. Domains is just different aspects of your life. There's some emotional reactions people have, so people will get depressed. There's lack of energy or loss of energy or fatigue. Pardon the new dog, sorry. There's pain, which we talked about, that doesn't affect everybody, but affects some people. And then, of course, one of the biggest problems with diabetic neuropathy is a loss of mobility, a loss of physical mobility. So this includes weakness, I think, and fatigue, but also a very dangerous and frightening loss of balance and position sense that happens. And then, of course, diabetic neuropathy will mess with people's sleep because some people will get periodic movement disorder, otherwise known as restless leg syndrome, or they'll just wake up with kind of neuropathic pain. In one study that they looked at symptoms for diabetic neuropaths, there was diminished pressure sensation, absent ankle reflex, and diminished vibration perception. So I put this slide in here to remind me to tell you that I've seen countless people with diabetic neuropathy or some sort of other distal neuropathy who don't have an ankle reflex, and that is used as a reason to indicate them for spinal fusion surgery, believe it or not. So they're often diagnosed with L5-S1 radiculopathies and like neural stenosis or whatever. They don't have an ankle reflex, and that's used as a clinical indicator for a problem that's really not the problem. The problem is a fundamental intrinsic systemic problem with connective tissues and nerves, and most diabetic neuropaths do not have an ankle reflex. The SF36, so this is a standard study that we use in medicine. There's the SF12 and the SF36. These are more of the patient-centered outcomes. So it used to be all our literature was surgeon-centered, meaning if I liked the x-rays, you got a good score. If I thought, the technique was good, you got a good score. Or like, if infection went down, like different objective measures that we looked at, and nobody ever really cared what the patient felt like. Well, now more and more literature is starting to look at patient-centered scores, and this is one of them. Neuropathy really affects physical function. It's far worse than people without neuropathy. And then the mental health is worse too. We just talked about depression. So mood disorders, things like that. Every 1 unit increase in pain, and that's on your 1 to 10 scale that you guys are probably all familiar with, or frowny face to smiley face. Every 1 unit will reduce the physical scores by 9 units and reduce mental health scores by 15 units. People with neuropathy are more socially isolated, and isolation and loneliness are one of the #1 killers we know about nowadays, and also dramatically decreased quality of life. They have more emotional distress that we already talked about, and of course, fatigue and poor sleep. And if you've listened to anything I've said in the past, you know that sleep is one of the #1 determinants of health and wellness. So neuropathy is really damaging overall and in multiple domains, as we talked about. Socially, emotionally, fatigue, physical balance. Think of any aspect of your life, and if you're a neuropath, it's going to be diminished in terms of quality. So 50% of type 2 diabetics, and of course, it's probably the same for type 1s, 50% of type 2s will develop diabetic peripheral neuropathy. You'll see it as DPN a lot, diabetic peripheral neuropathy. And this is up to, or just over about half, confirmed with known and validated screening tools. What happens is you'll get postural or balance defects or deficits. The brain doesn't really compute with the sole of the foot, and you don't have a normal sense of space or sense of where you are in space. What does this do? It increases your risk of falls. And then if you have postural problems, like the sagittal balance of your spinal cord is messed up, you're supposed to have this gentle curve forward in your cervical, back in your thoracic, forward in your lumbar, back in your sacrum. If that's not balanced, as it isn't with these postural defects in neuropaths, then you have spine pain and low back pain. And of course, being diabetic dramatically increases your risk of having low back pain, which is already pretty prevalent in the population, of course. We think it's because of connective tissue issues, lack of microvascular. In other words, it's almost like an ischemic pain. And then the postural and also the muscle, you get sarcopenic. You lose ability to really hold yourself up because the muscles are so weak. All of this conspires to increase your risk of not just pain, but also of falling. And if you fall, that is a whole nother ball of wax. And then, of course, reduced physical performance. You can't walk as much, you can't stand as much, you have trouble with self-care. It's really difficult to do almost anything in life, which of course will lead to problems not just at home, but at work. So the lifetime risk of a hip fracture from falling in a diabetic versus a non-diabetic, specifically with neuropathy, is vastly higher. So this graph shows you this. The red line, and this is as your age progresses. So the x-axis is years in life. If you can't see it, the y-axis is your risk of a hip fracture. After about age of 60, the curves diverge, and you have a much greater risk of falling and getting a hip fracture if you're a diabetic with neuropathy than if you're not. So it's yet another reason to not get diabetes, is you'll dramatically decrease your risk of a hip fracture because you'll have a better sense of space, a better position sense, and better balance and better postural control. Also, peripheral neuropathy doesn't just affect the sense of, how you feel things and pain, but it also dramatically affects quality of almost all connective tissues, to include bone. So hip fractures, we know the 1-year mortality is very high if you make it out of the first year, which something like 30 to 50% of people die 1 year after a hip fracture, if you can make it past that first year, you do better, but really you're not out of the woods till 5 years later. So diabetics that get hip fractures, not only are you going to get the hip fracture, but you're at increased risk of death too. So diabetic neuropathy is not really something that we should brush over lightly and just not take care of. So we already talked about it: pain, burning, tingling, numbness. The worst problem, or one of the biggest risk factors, or what people worry about the most when they're neuropathic, is ulceration. Why do we worry about ulcers? Excuse me. I think I'm allergic to the pollen outside. You get ulcers. If you don't get the ulcer treated properly, that leads to, of course, amputation, which is one of the biggest fears most diabetics have, is will they lose their foot? I get asked this a lot. I have people come to me who have been seen and treated at wound care centers for years or by other providers, and their wound is never healed, and that's their number one fear. We can put that fear to rest with a lot of new modern techniques, but it is a concern. So when you have a lack of normal sensation, normal ability to sweat, which we'll talk about, normal healing capacity, and then you're chronically overloading something because you don't really feel it, that's when you get these ulcers that don't heal, okay? It's just repetitive mechanical pressure or mechanical overload in one particular spot that can't ever heal. That becomes an ulcer, then the ulcer propagates, get worse. If it's not handled, yes, it can turn into some sort of amputation, either just a toe, part of the foot, or a BKA, or God forbid, even higher. So neuropathy, again, risk of increased risk of hip fractures, increased risk of ulceration. So there are really, really bad side effects of having neuropathy. What other symptoms might you have with neuropathy? Remember, diabetes doesn't just say, oh, you're diabetic, I think I'm going to damage your nerves, but I'm going to forget about all your other issues, and I'm not worried about your eyes, I'm not worried about your kidney, I'm not worried about your liver or your connective tissue. No, this is a systemic problem. If your nerves have gone bad, most people with neuropathy, you better check their eyes, you better check their kidney function, et cetera, because usually they're going to have chronic kidney disease, they're going to have lens defects in the eyes and have to get cataract replacements. They're going to have poor quality of bone. And the worst thing that happens is the sarcopenia and the osteoporosis, or the abnormal bone from the connective tissue disorders. So you're going to get thick, stiff, dysfunctional connective tissues, meaning tendons, all of the ligaments and capsule tissue around your around your joints will start to feel just not right. So this is why a lot of diabetics tell me they feel very stiff, they creak, they ache. It takes a while to get up because they're so stiff that they almost can't even unbend. Things like that. That all goes with the connective tissue abnormalities that happen. And then you lose muscle mass on top of that. So now you've got thicker, dysfunctional, stiffer connective tissues on top of weaker muscles. So it's even harder to move. And then you've got poor bone quality. And of course, all of this is usually, not always, but usually combined with obesity, which of course makes it even harder to move because you've got to carry more around. Plus you're chronically, constantly under inflammatory attack from the adipokines that the fat cells produce. So all of this is conspiring against you to make not just the neuropathy worse, but also all of the other aspects of the quality of life and your physical quality of life worse. And then remember this, all nerves are surrounded by gobs of connective tissue. So there's layers of connective tissue around each axon, and then around groups of axons, and then around fibrils. And then at each point where a nerve passes through any sort of other tissue, there's reticular connective tissue, fascia. So if your connective tissue is getting thick and glommed on and not right and stiff, then the nerves don't move right. Nerves can only accept up to 8% deformation before they become ischemic and don't work. In other words, they can only stretch a little tiny bit. So if they're stiffer or the tissues around them are stiffer, then it's much more easier to get things like compressive neuropathies or nerve dysfunction. So the most common complaints that I've seen for neuropathy, and this bears out in the literature too, the numbness and tingling, we talked about the pain, which is usually kind of a burning pain. classically we're taught stocking glove distribution. So it starts at the toes and slowly moves up, and then starts at the fingertips and moves up. Why? Because diabetes is going to affect the longest nerves first. So the nerves that are furthest away from the cell body, that are most at risk of receiving poor nutrition or being attacked by excess sugar, they're going to be affected first. Thus the toes, then on up, and then eventually the fingertips and the hands. Motor neuropathy, this is when you have those cramps, restless leg disorder, weakness, things like that. So the nerves to the muscles are being affected too. And then autonomic neuropathy, which a lot of people forget about, but is really common and really does affect quality of life almost as much, if not more, than the other types of nerves. Digestion problems, so gastroparesis, this is when the gut just stops working right. People get massively constipated, bloated, they can't eat right. It's because their gut motility is altered because of the nerves to the gut are also neuropathic. Urinary problems, sexual dysfunction. Believe it or not, one of the primary first signs of diabetes gone amok in men is erectile dysfunction. Heart problems, palpitations, things like that, arrhythmias, and then of course ischemic heart disease, which goes along with all of this. And then sweating changes. So if your autonomic nervous system isn't working right, your feet don't know when it's appropriate time to sweat or not sweat. And this is when you get skin changes like cracks and stuff in your skin, which of course let bacteria in. And then if your feet don't know how to sweat properly, that means they can't regulate their temperature properly, which also affects wound healing and skin quality. So all of this is happening all at the same time. Some people have the pain, the numbness and tingling, and then they're having all of these autonomic nervous dysfunctions too. So that's a video. This is, I put in a case example to kind of illustrate. These are the kind of patients I see pretty much every day during a clinic week. So a 57-year-old male, he's an operator at a plant. He's a shift worker, which of course to me means he doesn't sleep right. Presents with a chronic sore or ulcer on his big toe. He has some burning pain on the bottom of his foot, sometimes the top of his foot too. He tends to stumble, and he tells me every now and then he'll roll his ankle. And he has trouble putting his boots on in the morning. So, I asked him to show me on his foot where his ulcer is. And it's one of these things where somebody has to like take their hand and pick up their leg, and they can maybe sort of cross it, but not really. They end up using their other foot to point to where the problem is on the foot. And I watch people do this, and I know that they're just so stiff that they can't not move like that, which tells me in my brain that, yes, they've got a lot of connective tissue disorder too, and I need to address that as well. So why do the nerves go bad in diabetes, you may be wondering? Well, a number of reasons. There's the polyol pathway, which we'll talk about briefly next. You get nerve swelling and damage. Polyol pathway is just an alternative path to metabolize glucose when there's so much glucose in the system that your mitochondria get overwhelmed. Another way is advanced glycation end products. This is when proteins glom and stick together and abnormal proteins are created. There's increased inflammation at nerve endings. There's increased oxidative stress on the nerves. And then, of course, there's reduced blood flow to the nerves, because most people that have diabetes also have elevated LDL and triglycerides because of excess energy. And then, of course, that ultimately leads to atherosclerosis and plaquing, and you get less blood flow to the peripheral tissues, to include the long nerve endings. So I put a picture of a steak being cooked on a grill to tell you about advanced glycation end products. Anytime you sear a steak, cook a steak, bake a bread with a big crust on it, melt cheese with the nice, like saute stuff, and you got that umami kind of burnt cheese thing going on. All of that is advanced glycation end products. So that's when sugar combines with protein in the setting of high heat, and abnormal proteins are formed. That is what makes food flavorful, what gives food smell. Even the smell of coffee is a form of an advanced glycation end product. Well, what happens, this is happening in your body too. And the more of these you eat, you're going to add to what your body's making. And the more sugar you have in your blood system, i.e. diabetes, the more often you're making advanced glycation end products. And this is what creates the stiffness and the abnormal function of fascia and connective tissue, what causes cataracts, what causes some arterial or endothelial dysfunction, which of course promotes more atherosclerosis. So the advanced glycation end products, also known as advanced or early aging is what we really want to avoid. Now, you can't avoid it entirely. It's a normal process, but the more you slow down the production of or the accumulation of these things in your body, the slower you will age. So that's key, and one of the reasons diabetes is also called a disease of advanced aging. The smaller picture is an electron micrograph of the collagen bundles in a tendon of a rat. So that is actually what collagen looks like at the electron micrograph scale. Now you can imagine when you get abnormal connections between those little fibrils at the nanometer scale from these advanced glycation end products, they're obviously not going to be able to move correctly. And then what happens? You get a stiff Achilles tendon, you get stiff knee capsules, your back gets stiff, your arteries get stiff. Everything is just stiff and not right. And these are one of the things we want to avoid, and one of the reasons you get neuropathy from diabetes. The polyol pathway is when you have way too much sugar floating around in your blood. Your body's got to do something with it. So it will take the sugar and use a series of enzymes, one of which, and the rate limiting one, is aldactone reductase, I think. Anyway, it eventually converts sugar to sorbitol to fructose, and then fructose can be processed directly into fat, okay? Or fructose is 250 times faster than glucose in forming advanced glycation end products. So it's just even more of a disaster. So you've got a lot of excess glucose. Your body's like, I got to get rid of this glucose. I can't put in the mitochondria. They're overwhelmed. They're already working too hard and creating too many reactive oxygen species. What do I do with it? Well, I got this other pathway, the sorbitol pathway, the polyol pathway. I'm going to put it in there. And so you get more fructose, more fat, more advanced glycation end products. So it's a backup system that the body has to handle excess glucose, but it's kind of not a good thing. And you don't want to ever go down this pathway if you can help it. Now, one of the byproducts or one of the necessary components of this pathway is excess utilization of NAD+, which, if you know from my other talks, is one of our longevity molecules. And if you're sucking up all your NAD+ to process this excess glucose, only to turn it into fructose and then advanced glycation end products, well, you've got a double whammy. You're depleting the bioenergetics of your cell by taking up all the NAD, and you're creating more fructose, which then goes into fat and or advanced glycation end products. So one way to balance this is to take NMN, which of course will increase your NAD levels back to normal so that you can have normal bioenergetics. But it's just something to think about. This is yet another reason to really try to avoid excess sugar if you can. That's another video you can hit. So advanced glycation end products increase tissue stiffness, increases the rate of failure of tissues, so like tendon tears, muscle tears, fractures, microscopic fractures, Charcot-arthropathy, which is neuroarthropathy of the bone, makes it harder to stretch, makes it harder to use your muscles properly, your bones are brittle. And then again, this is advanced glycation end products in real life, a seared steak, toasted bread, wrinkles, all advanced glycation end products. I've been in surgery and operated on young, healthy people like trauma victims, and their tendons are typically white, shiny, glistening, pretty. Then you operate on an older diabetic for some other reason, and the tendons, believe it or not, almost look yellowed or brown in appearance. They're not glistening. There's no lubrication, very stiff. Why? Because they've deposited so many of these abnormal proteins over decades into their connective tissues that the tendon is now this like dried husk versus what it should be. All right, this is just showing you, we're not going to spend a lot of time on here, showing you how glucose converts to advanced glycation end products. Again, all the glucose needs are a few amino acids and some heat. Now, your body heat is enough of a temperature to do this. It just does it more slowly than if you sear a steak or, put it in a 500-degree pizza oven or whatever. So when you sear a steak, it happens in minutes. In this body, it's happening over years. So it'll turn into what's called a Schiff base first, and then that converts to an Amadori product, and that converts to an advanced glycation end product. So basically, there's 3 steps in this chemical reaction. None of them require enzymes. So there is no drug that can be created to stop this process from happening. Really, all you can do is don't eat as many of them as, try to reduce your intake as much as possible. And then also try to avoid excess glucose in your bloodstream. That's really your only weapons against forming these rapidly and rapidly aging yourself. So advanced glycation end products, which conveniently have the acronym AGE, can wreck your tendons, your bones, and your cartilage. We just discussed sort of how. I put this slide in to remind you that you do have a way to reduce your intake of these. Avoid ultra-processed foods, which we'll talk about, but ultra-processed foods are replete with advanced glycation end products because most ultra-processed foods are made in a high heat environment with a lot of extra sugar. One thing you can do is to avoid frying food as much as possible, or if you're going to, use highly antioxidant oils like olive oil. Obviously, deep frying food in seed oils, particularly reused seed oils, I think is probably a no-no. You want to avoid roasting meat if you can, although I understand it tastes delicious. Obviously, we're all still going to do that. I'm just saying don't do it as often as you probably do already. The other thing, which turns out humans have been doing this forever, and maybe evolutionarily we figured it out, maybe not, but if you marinate your meats in an acidic environment, that reduces the formation of advanced glycation end products. So marinades are a good thing if they've got acids, okay? So citrus, vinegar. If your marinade has that kind of stuff, you're going to reduce the formation of advanced glycation end products when you're cooking your meat. Another thing is lower temperature for longer and then cooking with moisture. So boiling, steaming, making soups, that kind of cooking, anything with moisture will dramatically slow down the production of these advanced glycation end products in your foods. So like when I cook my eggs, I try to use very low heat and just cook them longer to try to reduce the formation of these things. So those are just little pearls for you, but you really want to avoid these if at all possible. It's impossible to avoid all of them, but you can reduce your intake a little bit. All right, so nerve function. Really quickly, we've talked about nerve physiology in other talks, and if you're really into it, go watch those. This is the action potential. So nerves work on an all or none system. If they get enough voltage input, they will fire an action potential. So all of a sudden, a big positive charge drops into the cell, and then it spits it back out, and this propagates down a nerve. Okay, that's how nerves work. Almost like the electricity in your house. Think of it like turning on a switch, action potential, turning it off. So you have a neuron, the cell body, dendrites that go into the cell body that give input from other nerves. The nerve processes that information, whatever, tells the axon to send axon potential or action potentials. The action potentials go all the way down the axon, let's say from the brain to the toe, following this voltage-gated propagation, okay? And then when they meet a receptor in the toe, either a sensory receptor or let's say they're going to be working to move your toe, a motor end plate, then you're going to have a synapse. So the end of the nerve has to let out all these neurotransmitters that then hit that nerve cell body or dendrite and allow another system to work. So it's very intricate, very well designed, and requires all of these ion channels to work appropriately, all of the receptors to work appropriately, and you have to have the right electrolyte balance. This is why electrolytes matter. And again, it's all or nothing. So it's simply just movement of an electrical current down a wire or an axon. And this can be sensory nerves, motor nerves, or autonomic nerves, like we talked about, sweating, temperature control, things like that. So glycated nerves or glycated connective tissue nerves require more of an input to work, as do glycated tendons and connective tissue. So the more of those advanced glycation end products you have, the less this system works properly and the more effort has to go into it. So diabetic neuropathy takes years to form. Remember, I told you these advanced glycation end products don't form rapidly in the human body. It takes years, sometimes decades. Also, all of the other problems, the polyol pathway, the sorbitol toxicity, things like that, all takes years. So these are patterns of nerve dysfunction. One is hereditary. So some people are born with nerve dysfunction that takes years to develop. One of the most common ones in Louisiana, we're kind of a hotbed of it, is what's called Charcot-Marie tooth disease. So there's the Dr. Charcot, Dr. Marie, and Dr. Tooth. They all three got their name on it, so it's called Charcot-Marie-Tooth. This is a hereditary sensory neuropathy where people get really high arches. They develop foot drops. They roll their ankles a lot. They have skinny calves, and they have sometimes neuropathic pain and numbness and tingling in their feet. And then eventually it'll affect their hands as well. So that's a really common hereditary one. Number two, the most common, the one that I treat the most often is, of course, metabolic dysfunction of the nerves, diabetic peripheral neuropathy. Can also get toxic, sometimes chemotherapy induced. Three is immune mediated. I see a ton of people with autoimmune disorders that have neuropathy. For some reason, a lot of doctors aren't connecting the dots, but most people with autoimmune disorders will have a type of neuropathy too, and you got to keep that in mind. Then there's vasculitis and perineoplastic, meaning some people will get a neuropathy related to a cancer. I put this bottom picture in. Hopefully you can see it. On the left side are lumbar nerve roots in a normal person. The right side are lumbar nerve roots in somebody with neuropathy. And these are these newer MRI technologies that are available, not in Louisiana. I'm working on getting it into New Orleans. But this technology is amazing. You can actually see the nerve fibers with an MRI, and you can actually tell if somebody has diminished nerve function using imaging. So it's pretty awesome. Hopefully we'll get that into the States soon, and I'll be able to offer this to my patients. But I just want you to know these kind of technologies are there. They're being looked at, and they're being used and being studied. And hopefully soon we'll have even better diagnostics to help you know if you have this problem and then how to treat it, and also to know if our treatments are working. So this is another diffusion tensor imaging or MRI of the sciatic nerve. A is a normal sciatic nerve going down the thigh. B is a pre-diabetic, and C is a diabetic. Look at the difference in caliber of that nerve and how many functioning axons there are. So, and I see this a lot. I know that people with type 2 diabetes have dysfunctional sciatic nerves, dysfunctional lumbar nerve roots, dysfunctional spinal nerve roots, but it's so often called regular low back pain or because of a fender bender or because of this or that. But fundamentally, it's a diabetic systemic problem. And now we have imaging to prove it. Look, the sciatic nerve is probably a third of the size of a normal one because of axonal nutrition depletion and atrophy. It is pretty astounding what this disease does to people. And I mean, I'm just here to tell you, try not to add sugar to anything. When they have diabetes?
When they have like sciatic pain and diabetes at the same time.
Well, I'm going to talk about treatment. We're going to talk about treatment coming up. Why, does somebody have a question? You have a question. My producer had a question. I will address my producer's question later. All right. So axonal atrophy, think about that. Remember I told you diabetics lose muscle mass, you get sarcopenic. Sarcos muscle, penia usually means less of, so osteopenia, thrombocytopenia, all that means you have less of it than you should. Axonal atrophy is super common in diabetes. So the axons themselves are diminished in caliber and function, and then there's fewer and fewer of them over time because of nutritional degradation. So it happens far away from the cell body. Those parts of the nerves are not getting the nutrition they need. Everything a nerve needs has to pass down the whole way of the nerve by way of microtubules in these little baby proteins called dynesin and kinesin that literally take steps along the microtubule. They require energy to do this, to lock and unlock on the microtubule. And they bring organelles, proteins, vitamins, minerals, nutrition, mitochondrial, whatever. That's what gets to the axon to help it heal and stay healthy. Well, guess what happens in diabetes? That is not working right. And so the far ends of the nerves aren't getting the right nutrition, and they start to degenerate and fall apart. And you get length-dependent axonal degeneration and atrophy, super common in diabetics. Myelin, you may not think about a lot. Myelin is the insulation on the nerve fibers. This top picture shows you that thick green band is myelin. Underneath it is a nerve without myelin. So some nerves have myelin, some nerves don't have myelin. Most pain fibers do not. Most things that sense position and motor axons do have myelin. What does myelin do? Just like insulin in any nerve or any wire, it's going to increase the efficiency of conduction. So it's going to make the nerve work faster, more efficiently. So your larger vibration sensors, pressure sensors all require myelin. The unmyelinated ones are the smaller nerve fibers, the type Cs. They work a little bit slower, and these are the ones that carry pain. But axonal atrophy will happen in all types of nerves in diabetes. So it's a fatty substance, myelin is. It's made from lipids. The lipids are not always bad, okay? Made from lipids, some proteins, and it's an insulator like we talked about. The signals are faster. And if you don't have enough myelin, not only can you not move properly, and you may have a lack of vibration and position sense, but you also start to not think correctly and get a brain fog because you need myelin in your brain too. So the myelin is everywhere, insulating things and making things work better. And if you have a demyelinating problem, it's not just going to affect you peripherally, it's also going to affect you centrally, meaning spinal cord and brain. Okay? The graph on the bottom shows you the speed of conduction if you have a myelinated nerve versus an unmyelinated. So the unmyelinated is never going to be as fast as a myelinated nerve, except in the very, very nanometer, like teensy tiny size, which is a whole nother discussion. So myelin in the peripheral nerve system is made by something called a Schwann cell. And in the brain, it's made by an oligodendrocyte. Just little factoids. Okay, so just remember, electrons are electrons. Universally, as far as we know in the universe, they behave the same no matter what. Okay, so this is a cable wire with the copper coils surrounded by what? Insulation to separate them from each other, to make them work more efficiently. You have the same thing going on in your body. Myelinated, insulated nerve fibers are going to work better. They're going to be more efficient. They're going to take less energy. It's going to have faster propagation of the electrical current versus non-myelinated. The bottom picture shows you the cross section of a nerve, like a slice of bread. What happens is a Schwann cell just starts spitting out this lipid layer, and it kind of just wraps around the nerve. And each Schwann cell is responsible for a certain part of the nerve. So you have to have healthy Schwann cells, enough nutrition, enough of the right lipids, and enough of the right signals going into the nerve to tell the Schwann cell what to do. So this bottom video is showing you nerve. The one on the left is an unmyelinated, and you see the charge just kind of drift down. On the right is a myelinated nerve, and it's just hopping. So what's really happening is your myelinated gap, myelinated gap, myelinated gap. What that does is it makes all of the ions congregate in the gap. That's called a node of Ranvier. And then that's where the action potential happens. And then the action potential jumps from gap to gap to gap. That's called saltatory conduction. And this is why it's so fast. So it's like, think of it like a little puppy running versus a gazelle hopping across the savannah. So much faster and efficient. The top picture is showing you a good nerve with beautiful myelin and a normal gap junction, okay, or node of Ranvier. The bottom one is like somebody with Guillain-Barré or multiple sclerosis. The myelin sheath is just destroyed, not right. The gaps are missing. And so now these action potentials have to move the same way as they would in an unmyelinated nerve. And it's just slowed down. The myelin develops while you're in the womb, the 5th month of gestation, and will continue to develop as you get older. The timing of your maturity, so as humans develop certain motor skills, certain brain skills, the ability to talk, think, etc., it matches how myelin is grown and developed and laid down in the human body. Brain myelination continues until the mid-20s. This is why it's important to emphasize all your teenage and early 20 kids that their brains are not fully developed and they lack executive function. So they don't have impulse control. They think they know everything, but they don't know everything. But they really believe that they do know everything because they don't have enough myelin in their brain to know what they don't know. So I think your best way to fight this is just educate them on the physiology of the fact that the brain is not fully developed until 25. This is why it's hugely important to avoid marijuana in that age group if you can, okay, because it's been shown to induce psychosis in that group of people because their brain's not fully myelinated. And then, of course, myelination in the brain is required for executive function or control, the ability to control impulses and think through problems, and also for higher thinking, like step 4 problem thinking, or 4D chess, as some people say. So people with Guillain-Barré, multiple sclerosis, and some other disorders have damaged myelin. But people with diabetes and peripheral neuropathy from metabolic dysfunction also have damaged myelin because the Schwann cells can't get the right nutrition or blood flow to function properly. So myelin is hugely important and something we don't often think about. And I just put this slide to remind you how complicated all of this really is. And honestly, in surgery and in medicine, we really don't know. I think we've just scratched the surface of neuropathy and nerve function. The art of fixing peripheral nerves is just now like in its 10th year of like really starting to catch on. I do a ton of nerve surgery, probably more lower extremity nerve surgery than anyone in the state. It's very common in the upper extremity now. People are starting to do more in the ENT world. And when I say nerve surgery, I mean, we've realized that we can actually fix some of these problems surgically, not all of them, but some of them. And we're starting to understand why that works and how to make it work even better. But nerve dysfunction comes down to really everything that I've always talked about with you guys: oxidative stress, nutritional deficiencies, and inflammation. If we could control those things, a lot of these neuropathies won't happen to people, and then we won't have to worry about how to treat it and what's going on. So again, like everything else, prevention, prevention, prevention. So back to our patient, JT. So he's got this weak ankle, painful thing. He's got this toe ulcer. He's working at the plant. What happened? Originally, he's prescribed gabapentin and Norco, so a narcotic and an anti-seizure medicine. And then, of course, his doctor told him to stop working, stay off of work, don't do anything, avoid all activity because it could get worse and you might hurt worse. Told him you can't wear steel toe boots, so of course he can't go on the plant because that's required by OSHA. And then he orders wound care. So JT, he's not working now. He's avoiding all activity. And now he's got to go to the wound care clinic every week. And they whittle on his wound like this slide shows you. And this is going on for a year now for this guy. And he still has the wound, the pain, and not working. So what are the implications of poor nerve function? Well, JT's kind of showing us. With diabetic peripheral neuropathy, 18% of people lose productivity in their everyday life, okay? Because of pain, fatigue, numbness, whatever. There are 2.5 more hospitalizations in this group. And anytime you are hospitalized, you have a much longer recovery. Or anytime you have surgery for any reason, you have a much longer recovery. An $80 billion increase in costs every year for over 10 years. So at least $8 billion a year. These people have to retire early. They often have to medically retire because of pain, balance deficits, and reduced physical performance. What does this lead to? Reduced wealth and reduced family wealth. And then, of course, they need long-term social support. And this is because of things like amputations, chronic pain, or they're unable to care for themselves. What does that mean? You got to spend on long-term care. So diabetic peripheral neuropathy is a quality of life issue and a financial issue. It is actually bankrupting people in this country. So the loss of work days. Most people in a year, think about this. A diabetic neuropath would lose up to a month of work time because of their disease process. That's incredible. And then the loss of time for diabetics without neuropathy, so just straight up diabetes, loss of work days is just 12. Still a lot. It's like 2 weeks off just because you're diabetic. But a month off if you have neuropathy. And then for people without diabetes, less than 12. Loss of 2 hours every week, 52% of diabetics. So like taking off time because they hurt so much or something, had to go to a doctor's office, who knows. 1.4 hours less each week if it's non-painful neuropathy. So that's going to be the people that have wounds, but they don't hurt. There's absenteeism, massively present. So they're at work, but they're not really functioning. They're just sort of sitting there, not doing a lot. Absenteeism is missing work. Presenteeism was what I just talked about. Reduced performance, they're missing deadlines, poor concentration, they're not catching on what's going on in meetings, things like that. And then, of course, poor function at manual tasks. So if you have a manual job, you're having trouble standing, having trouble walking, balance is off, a fall risk, which means you're a risk to everybody at the job site, including yourself, trouble with operating heavy machinery, things like that. And then, of course, if your injury risk is high, you're going to have more injuries. And then, of course, we already said it, you're going to have longer recovery from any given injury. Anytime I see a workers' comp patient that's diabetic also, I have to argue with the case managers often that they're not going to follow the normal timelines of recovery. You've got to give them a few more months because of this underlying issue. And then, of course, a lot of these people, like JT, they're going to end up going on early retirement or have disability. What does that mean? A massive loss of wages over time, which means less investment and less wealth building. So your retirement is going to be poorer. And then, of course, for the society and the companies, that institutional knowledge, everything that JT knows about that plant and he could teach to the younger people, that teacher is gone. And we're just losing massive amounts of knowledge in this country. So JT's wound gets worse. He's been in wound care for a year now, remember, not working. His pain is still there. And of course, what happens anytime you're on Norco, you escalate your dosing. So he's taking more and more pain meds. He's gaining weight. His A1C bumped up. He's lost his job now. They had to replace him. The plant couldn't just wait for him. So now he's unemployed. He's still going to wound care. He eventually loses all his savings. He loses his health insurance because he lost his job. Now he's got to go on Medicaid. He files for disability, but of course, even if you get disability, it's a 2-year wait to get Medicare. Meanwhile, you're on Medicaid. So then he can only go see the doctors that take Medicaid. So JT is in a world of hurt here. What? Oh, yeah. So I generated this image with AI for this talk, and I put it in here because it cracked me up because it put a 3rd foot. So AI is not perfect yet, by the way. So what are the common concerns people have, and you might have, or you might have a family member that has? Obviously, nobody wants an amputation. That's a primary concern. But they want to know, is it going to get worse? What if I do nothing? Will my life get worse? Is my quality of life going to decline? Am I at risk of an amputation? Am I going to lose my independence? A lot of them, if you ask them, will admit that they are sad, they are frustrated, they are starting to become depressed, they're starting to socially isolate. Most people are scared to death because they have no idea what their future is going to look like. And unfortunately, a lot of these people still have dependent children, or they're raising their grandchildren for some reason or the other. And, you know, so you got these 60-year-old diabetics with these problems, now all of a sudden responsible for their grandkids. So they've got to be functional for at least another 20 years. So it's all very sad. And what's really sad about all of this is it's preventable. Totally preventable with just diet and lifestyle. So the principles of wound care, I just want to throw this out there. This isn't really a wound care talk, but remember, the wounds are forming because of dysfunctional nerves. I put these slides to show you that there are surgical options for wounds. Now, most primary cares do not think about people like me when they have a patient with a wound. They don't refer them to somebody like me who knows how to do orthoplastic surgery and nerve surgery. They always send them to a wound care center or a podiatrist. That's fine, but I want you guys to know, for your friends and family, if you have somebody with a chronic wound, there are surgical ways to get it covered very quickly where they don't have to go to a wound care center for like a year or two and lose their job like we just talked about. So surgical offloading, orthoplastic techniques with rotation flaps, island flaps, different things like that really works faster, better, and it's less financially detrimental to people than these chronic visits to the wound care. Now, wounds are an excellent business as long as the wound doesn't heal. Think about that. 28 to 32 billion per year annual Medicare spend on wounds. Okay, this was a study that was just released. So if you do a quick procedure and you treat the wound, you are not a wound care center's friend. So I can tell you that I get no referrals from wound care centers because they know that the wound's going to be healed if they come to me. Nutrition, hugely important. Now, there was a study where they looked at arginine, glutamine, and HMB, which is hydroxymethylbutyrate, which I think is related to the ketones in one way or another. Arginine and glutamine are important amino acids. I put this in here to remind me to tell you about protein. One of the things we check is albumin and prealbumin and lymphocyte levels when we're seeing if somebody's able to heal a wound, or at least those should be checked. Albumin shows your overall protein level in your serum. Prealbumin's even more sensitive, and then lymphocyte count matters too. That's a white blood cell. What this is showing us is if your protein status is good, in other words, if you're not malnourished on the protein level, if you don't have enough amino acids in your body, you're not healing anything. So protein intake is so important. I've got a lot of diabetics now after bariatric surgery, or they're on GLP-1s like Ozempic or Mounjaro. Well, they're not really wanting to eat at all, and I just have to over and over emphasize to them, you've got to eat your protein. Definitely, you've got to make sure you get your protein in. Why? Because you have to have the fundamental building blocks for tissue to heal. What is skin? Collagen. What is skin, fascia, connective tissue, and everything around a nerve? Collagen. What is collagen? Collagen is protein. And every third position is glycine. This is why I tell a lot of people to take glycine, one of the amino acids we have, because glycine is every third position on collagen. What else is important for collagen formation? Vitamin C. The collagen bundles cannot properly cross-link together to make a big structure without vitamin C, which is needed for the reaction to do the cross-linking. So nutrition is so much more important than anybody really gives it any credit for, particularly doctors. And again, it's not their fault. Only 13% of us were taught anything about nutrition. I've honestly had to teach myself everything. I learned nothing about nutrition in medical school and certainly not in residency. So nutrition makes all the difference. And also remember, there are ways to surgically treat wounds. You don't always have to spend your life at a wound care center. So how do we diagnose neuropathy? You may think you have neuropathy, you may not be sure. These are the things we look for. The length-dependent nerves should be checked first. So toes, feet, and then maybe hands. You got to check the sensory function. You got to check motor function. And then autonomic things. So like dry, cracked skin, like this picture of the heels here. Anytime I see that, I kind of automatically already know that person's at least got autonomic neuropathy. The diminished Achilles reflex. So checking the ankle reflex. If you don't, when you tap the Achilles, if the foot doesn't reflexively tap down and they have a lack of or a diminished Achilles reflex, another sign. Symptoms like dry eyes, dry mouth, constipation, and then loss of hair, particularly in guys. If you see hair down the mid-calf and then suddenly it disappears, I know they've got autonomic neuropathy and lack of blood flow to that area. So different little clues we look for clinically. Then we do things called nerve conduction studies with electromyograms. And this is when we're actually testing by stimulating a nerve and then having a sensor, you're actually testing the conduction velocity, the size of the waveform, or how many electrons are moving down and things like that. So we can actually tell if a nerve is missing myelin, is missing axons, combination of both, or if there's just ischemic problems. Now, I see a lot of patients with pain from nerve things. And this study is always falsely negative unless you look very, very closely at it. So this doesn't pick up pain reasons unless it's so far gone that they also have motor and sensory dysfunction. But when you have somebody with peripheral neuropathy, this is such a great study to do, especially, and you have to have somebody that knows what they're doing it, by the way. Because it gives you a baseline of the function, so you'll know if your treatments are working later. And it also can actually help you figure out what type of neuropathy do they have. I order a lot of these studies, and I finally found somebody awesome to come in and do them, and he actually drives in from a whole nother city for me twice a week. It's that important to have somebody you know and trust doing these studies. So again, that's another diffusion tensor imaging to remind you we're starting to get better imaging, but we also have to get blood work, right? I always check a CBC, an ESR, which is a test for inflammation, a complete metabolic profile, and you can look at B12 levels, protein level, your A1C, which we'll talk about, kidney function, liver function. And then if you want to get really esoteric, you could start looking at electrolytes, all the other vitamins, but you can do nerve, antibody, and muscle testing, less common, vasculitis testing, immune function testing, and then of course you can do an infectious workup. So all of this is important. I do all of this: clinical examination, electromyogram, labs. And then we'll do a biopsy of the nerve. That's more if you're looking for like an inflammatory neuropathy. And then you got to find a sensory nerve that's not that important, because once you biopsy a nerve, you basically just damage the nerve completely, right? There are some newer, higher resolution ultrasounds. So you can actually ultrasound nerves. When I do nerve blocks in clinic and to test to see if a nerve is a source of pain, I'll often use an ultrasound to identify the nerve and make sure I get next to it, but you don't want to inject into a nerve. You just want to be near it. But nerve imaging now is getting so good, you can actually see where a nerve is dysfunctional or where the fibers aren't lining up right, or it's filled with scar or fat or something. And then, of course, the diffusion tensor imaging or tractography, MRIs we talked about. So our imaging is starting to get to the point where hopefully one day you can just get an imaging study and you won't have to go through the EMG and the blood work and all that. So it'll be less invasive. But right now, the technology's there, but it's not everywhere. And it's still, of course, probably not covered by most insurance companies. Go figure. So the most important thing for you to know and for you to do and for you to make sure your family members do is diet and A1C control. Mediterranean diet is by far my favorite, by far been studied the most to treat diabetes, to manage diabetes, to prevent diabetes. There's also things like the paleo, the carnivore, the South Beach, the keto. All of these probably have their place and their role, and I've told people to go on them for different reasons. But the vast majority of people would be fine on just the Mediterranean diet. That's how I try to eat, how my family tries to eat. Not only is it flavorful and a great lifestyle pattern, and the food is accessible and affordable, but it works. And it's been studied and it's been proven to work. Every point that you increase in your HbA1c, okay, your hemoglobin A1c, means that you've had an increase of 30 in your average serum glucose over the past 3 months. Why is that? Red blood cells live about 3 months. So the A1C is checking the average blood glucose for the lifetime of that red blood cell since it was formed. And A1C is hemoglobin. A1C is the advanced glycation end products that have glommed on to the proteins in the hemoglobin. So the longer they've been swimming in a bath of sugar, the more AGEs or advanced glycation products are going to be stuck on the red blood cell. That's what we're measuring when we're measuring your A1C, is the advanced glycation end products sitting on your red blood cells, because it tells us, it's a proxy for how much glucose they've been swimming through for the past 3 months. So remember, if you're 5.2, great, you're probably average blood glucose under 100. Once you get up to 6, you're at 126 average. So you're basically diabetic. In America, we don't call it diabetes till 6.4. 6.5 A1C is an average blood glucose of 140, which is 50 points more than where it should be. And this is showing the hemoglobin. So that's an advanced glycation end product next to a hemoglobin. And then the blue dots on the big red circle, the big red dot is the hemoglobin or the red blood cell. The blue dots are the glycated hemoglobins that start to conglomerate and fill the red blood cell. So the red blood cell is dysfunctional, obviously. The hemoglobin can't hold the oxygen properly, but it's really a proxy for telling us about your sugar. So this graph just shows you glucose is on the x-axis, A1C is on the y. As you have more glucose, your A1C goes up. So it's a way for your doctor to know how you've been acting the past 3 months. So you may have a perfect glucose the day you go get your blood work at the doctor's office because you fasted and maybe you avoided sugar the day before. But the A1C tells us what you've been doing the 3 months before. More importantly, it tells us if your medicines, if you are diabetic, if they've been working. So foods that support nerve health that you should be eating, fatty fish. Now, I say that, but I want you to know that I don't really eat a lot of seafood because I don't trust the fishing industry at all. And a lot of the fish is farm raised. They inject dyes into it. There's no omega-3s in them. So I supplement with omega-3. But theoretically, if you're getting a perfect wild-caught, non-polluted fatty fish, you should eat that 2 to 3 times a week to get your omega-3s and D. Leafy greens, high in B vitamins and antioxidants, also calcium. One problem with leafy greens is they also sometimes have oxalates. So if you're at risk of kidney stones, you kind of need to avoid those. Nuts and seeds will give you a lot of ALAs, which your body will convert to omega-3s. Whole grains give you a fiber, and that's not on the slide, but fiber is a real reason you want to eat those. You'll have B vitamins with it too. Legumes like beans, again, fiber, protein, B vitamins. Lean proteins, or at least grass-fed, grass-finished. So I try to only eat grass-fed, grass-finished or cage-free or organic meats because you're going to have a healthier meat with packed full of micronutrients, and it won't have a bunch of omega-6s and pesticides and chemicals in it. Dairy's reasonable as long as you're not eating it all the time. And then aged cheeses actually are really good for K2. So you'll get more vitamin K2 with things like natto, Parmesan, and whatnot. And then your fruits, so pigmented fruits like cherries, blueberries, strawberries, they're going to have antioxidants. And then citrus has a lot of micronutrients in it that are awesome for immune system and brain function. So I try to eat 3 or 4 oranges a day, believe it or not. I never drink orange juice because orange juice is basically just a shot of sugar. You only eat the whole oranges because you're getting the fiber and everything else with it. Vegetables, obviously, I mean, eat your veggies. There's really nothing bad you can say about vegetables. They're mandatory for good health. A true Mediterranean diet, you're going to have 9 servings of fruits and vegetables, different fruits and vegetables every single day. Now, unachievable, I get it. That's why I supplement. But theoretically, that's what we should do. Most important, avoid sugary, high sodium, and processed foods. So if you just avoid ultra processed foods and excess sugar, you're going to at least stop the nerve damage where it is. And then hopefully over time, you'll reverse it with a better diet. Key micronutrients you're looking for in your diet or you supplement with them. The B vitamins necessary for DNA synthesis and tissue repair. And also nerve function is heavily reliant on B vitamins. That's why a lot of people with B12 deficiencies will have neuropathies. Vitamin D, there's D receptors everywhere, especially on immune cells and nerve cells. Alpha lipoic acid is a wonderful antioxidant that treats nerve pain and promotes nerve health. Omega-3 fatty acids, very important for the lipid insulation and also for the cell membranes in your brain and in your peripheral nerve system. Also highly anti-inflammatory. Calcium, not only do you need calcium for your bones, but every synapse to dump out the neurotransmitters have voltage-gated calcium channels. Calcium is the #1 way cells communicate to each other. Very important. Vitamin C, I already told you why. Also, it's a strong antioxidant. Vitamin E, a fat-soluble antioxidant. Alpha lipoic acid is fat and water-soluble. It's got dual action. Vitamin C is water-soluble. Vitamin E is fat-soluble. They're going to work in different parts of the body. I love ALA for nerves because it'll get into the water-dependent tissue portion and the fat-dependent. PEA, palmitoyl ethanolamide. You're making some right now. I'm making some right now. We probably just don't make enough. I take this every day, and I definitely tell my diabetics or anybody with neuropathy to take it. I take it for brain health and longevity and, to make sure I never have nerve problems. But this actually will treat nerve pain, and it's a first-tier treatment in a lot of countries. It's a fatty acid amide in the same family as the endocannabinoids. Okay, so like anandamide and things like that. It reduces inflammation at the very tiny nerve endings at the length dependent and around joint capsules and in muscles. So people with a lot of pain, I put them on PEA, ALA, and then other things, but that seems to really tremendously drop down nerve-based pain. So what foods to avoid? Basically the American diet, okay? Now, once in a while, fine. Your body can handle any toxic dump once in a while and process it. We're built for that. We evolved on a very scary planet, right? So you can handle a bad meal at a restaurant once in a while. You just cannot eat like this anymore all the time. You've got to start making your own food with real foods. So sugary snacks, anything with high sodium, because usually they're putting high sodium in it combined with excess sugar to trick your brain to make you want more and more. Gluten, that's variable. A lot of people can handle gluten. Very few people are truly gluten sensitive, okay? Really, gluten means you're eating too many refined carbohydrates is probably all that's really the problem. So just avoid refined carbohydrates like white breads or crackers, things like that. Too much caffeine and alcohol in excess, that's a toxic load. You don't want to have too much of that. Processed foods, we already talked about, usually made in high heat with deconstructed chemical elements out of real foods, put together, glommed together with chemicals in some sort of solvent, and then packaged up nice and pretty, injected back with some vitamins and minerals and food coloring to make it look like food, and then they serve it to you in a plastic bag. Let's try to avoid that. And if you can avoid one thing besides excess sugar, like don't dump sugar into your coffee or your tea or whatever, fast food. Fast food restaurants are highly palatable. Almost every healthy chain closes and goes bankrupt. Most cities don't have tons of salad shops, right? Nobody wants these things because they're not addictive and they're not highly palatable. Fast food is. But just know they're using the lowest grade ingredients. They're reusing seed oils over and over again. It's all ultra processed. And it's basically filling you with chemicals and stuff you don't need. And if you have neuropathy, it's definitely making it worse. What must you eat or should you eat? Olive oil, 100%. If you've got any kind of vegetable oil in your house, get rid of it, replace it with extra virgin cold pressed olive oil. Has to be in a dark container, needs to be kept in a cupboard in a cool environment so it doesn't denature and get toxic. Extra virgin cold press, preferably organic olive oil is going to be one of your best weapons against diabetes and your best ways to treat neuropathy and poor nerve function. Avocado oil has a little bit of a higher smoke point, so some people like it better for sauteing and cooking, but you can saute in olive oil, you can fry in olive oil, it's fine. Whole grains, hugely important for the fiber, or you got to start taking some fiber supplements. What? Oh, they know. I don't need to go through what whole grains are. So olive oil from the fruit of the Olea europaea, I probably said that wrong. In a review of a review, so this is an umbrella review, it's a study of all of the systematic meta-analyses of olive oil. They basically said, yes, in fact, olive oil has a tremendous number of health benefits. It reduces risk of cardiovascular disease, it reduces risk of cancer, reduces death rates, reduces diabetes, and you can check for metabolic syndrome with certain biomarkers, and it reduces inflammation. So olive oil, if you're worried about any of these, heart problems, cancer, dying, diabetes, you need to eat more olive oil. More importantly, you need to replace crappy oil with olive oil. Has monounsaturated fats. It's sort of a different form of energy for your body that your body likes better and is anti-inflammatory in and of itself. And really good olive oils, the cold pressed virgin organic ones, are going to have really high polyphenol counts, which is a plant antioxidant. So I can't say enough about olive oil. So in neuropathy, olive oil in neuropathy. So it's antioxidant. Remember I told you one of the problems with neuropathy and damaged nerves was from oxidative stress. All that means is you've got too many free electrons running around trying to bind to make a pair, and they damage whatever they bind to. So if you have an antioxidant, that means you're putting a molecule in there that will grab that free electron and keep it from damaging a cell membrane, keep it from damaging a protein, keep it from damaging DNA. So you need antioxidants, and olive oil will give you some of that. And those are the antioxidants: oleocanthal, oleuropein, and hydroxytyrosol. Also highly anti-inflammatory. The monounsaturated fats are anti-inflammatory, and oleocanthal has similar properties to ibuprofen, but it's all natural and it comes with all these other benefits. The monounsaturated fatty acids, the MUFAs, can reduce inflammation. We already talked about that. Olive oil improves your insulin sensitivity. It makes your insulin receptors work better, and you have better nerve regeneration. So I'm a surgeon. I fix nerves, I repair nerves, I release nerves, I do nerve transfers, I do nerve grafts. Nerve regeneration is the only reason any of that works. So the more nutrition you can get to a nerve, the better nutrition, the more it's going to come back. I put a picture of this shrimp scampi here so you know you can still eat really healthy, fun food. Whole wheat pasta, shrimp, wild caught, of course, cooked with olive oil, maybe a little bit of avocado oil, some citrus to reduce your advanced glycation end products, right? And then herbs. Herbs are massive firecracker houses of antioxidants. So don't go light on your spices and your herbs. Whatever you like, add more. You can't get enough herbs and spices, I think. Must-haves for the diabetic kitchen continuing. Whole grains. So the pearl you need to think about with carbohydrates is 10-to-1 ratio. At least 5-to-1 is better. It's hard to find 5-to-1, so somewhere between 7 and 10-to-1 is what you're going to find. What am I talking about? Carbohydrate to fiber. Every label now has to say the amount of grams of carbs and the amount of grams of dietary fiber. Check the ratio. If it's 40-to-1, it's probably not that great for you. If you're going to eat that, make sure you have extra fiber in the meal or you take a fiber supplement. You really want to look for 10-to-1. So all of these keto, which are all ultra processed, by the way, keto breads and keto crackers and keto this and keto that, all they're doing is adding fiber in to get that ratio better. Therefore, it's keto, right? You could do that too by taking fiber supplements, more likely than not. Legumes like lentils, things like that. Beans, hugely important in the diabetic kitchen. Nuts, nut butters, herbs, we already talked about that. Popcorn, highly fiber filled, okay? personal favorite of mine, I pop my popcorn in olive oil. Why? Because I want the antioxidant and I don't want seed oil. And then eggs and lean proteins. I put a picture of a farm-raised egg and a cage-free organic egg. Look at the difference in the yolk. Healthy eggs will have a dark orange yolk. Crappy industry-produced, highly processed eggs will have a very pale yellow yolk. Why? It's a third less cholesterol. The farm-raised has more cholesterol. So good free-range, pasture-fed organic eggs will have more omega-3s, more vitamin E, more beta-carotene, all important antioxidant structures, anti-inflammatory molecules, has less cholesterol, less saturated fat, and more vitamin A. More omega-3s is the key. This is why you want to, yes, spend a little bit more at the grocery store to get high-quality ingredients. No one could ever say enough about fruits and veggies, in my opinion. Here's some turmeric with some ginger with some tart cherry. That is in our Joint Health Multi. I don't have the time or a big enough stomach to eat enough turmeric to get what I need, so I supplement. Ginger, studied for anti-inflammatory and joint pain, highly effective, also good for the digestive system. Tart cherry, remember we talked about the pigmented fruits and how they produce antioxidant molecules that are necessary. Also acts like COX-1 and 2 inhibitors, so like ibuprofens and Celebrex. It'll down-tamp that enzyme that makes you feel inflamed, but it does it in a way without the side effects of these synthetic drugs. Herbs, can't say enough about them. Marjoram probably has the highest antioxidant content along with bay leaves. So anytime you can cook with herbs and spices, I probably would. So what does diabetes matter? Why am I even telling you all of this? 500 million people worldwide are obese, and the count keeps growing. This is a real carbon capture, I think about it, in the cycle of life. So all these people are walking around as carbon sinks because they're storing so much energy. The prevalence is increasing. So 13 to 30% of Americans are obese now, 1 out of 3 of us, and that's growing, and it's growing in kids. Diabetes is a major human health threat. We think there's going to be about 600 million diabetics in 2035. There's about 300 to 400 million now. Back in 2006, there were only 150 million, and that was still a lot. The Mediterranean diet, as described by Ansel Keys in the 1960s, is not a low-fat diet. Low-fat was a myth propagated by our government and all of the dietary associations for years. The Mediterranean diet is up to 40% fat, up to 60% carbohydrate, and up to 30% protein. Obviously, you want it to equal 100%, so there's a range. But you don't have to be scared of fat or protein. You just have to eat the right fats and the right proteins. But look at that, 40 to 60% carbohydrate. Everybody's scared to death of carbs. But what are vegetables and fruits? They're carbs. You have to have carbs. Low-fat diets are not needed or helpful. There's good fats, there's bad fats. You want good fats. Whole foods, that's all you want. You don't want partial and fake foods. In other words, the American diet. Can't get enough fiber. Fiber will help many ways, but it does ultimately feed the gut, which helps produce neurotransmitters, which help your nerves function better. And then all the micronutrients we already talked about. So what do you avoid in your diabetic kitchen, or if you don't want to get diabetes, or if you want to treat your diabetic neuropathy? Basically, you can't shop in an American grocery store. Well, that's silly. Of course, that's the only place you're going to shop. But remember, 80% of the products sold in an American grocery store are ultra-processed foods. So you really have to be selective in what you're looking for. Try to avoid anything that says added sugar on the label. If there's any added sugar, try to walk away. And again, the carb to fiber ratio really matters. So kind of keep that in mind every time you're shopping. This is your diabetic friendly plate. Half of it needs to be non-starchy vegetables and fruits. About a quarter of it can be lean proteins. About a quarter of it or a little bit more can be your whole grains, maybe a starchy vegetable like a sweet potato or something like that. There are plenty of one pan and sheet pan recipes out there that will achieve this for you in a very simple, easy fashion. Try to only use olive oil when you're cooking this. To make sure you're always eating healthy, be your own sous chef. So pre-chop your vegetables Sunday, package them up. They're there for the whole week. Pre-cook your protein so you can just quickly heat them up, things like that. And then importantly, if you eat a salad before your main meal, that has been shown in studies to reduce the overall food volume that you eat by 12%. So just simple tricks like that. Eat a salad before you eat, take a short walk after you eat. You're going to eat less and you'll reduce your blood glucose because walking after a meal drops blood glucose somewhere from like 20 to 30%. So just little tricks, common sense things that you probably don't think about, you're probably not told to do, but these are basic things you could do to dramatically help your neuropathic condition. So there's an inverse relationship for obesity in the Mediterranean diet. In this study, it was a 54-month diet, and the people that stuck to or adhered to the Mediterranean diet had reduced waist circumference over that time frame, reduced glucose in their serum, reduced insulin levels, and they had a reduced HOMA score, which is a fancy way to check your insulin sensitivity or if you're insulin resistant. So again, proven to work. The Mediterranean diet is a way to go, and it actually, all of those, that's part of metabolic syndrome. So I think the last figure was something like 97% of Americans are metabolically dysfunctional. There's only 7% of Americans that are metabolically okay or perfect. The Mediterranean diet treats almost all aspects of that metabolic dysfunction. So if you're not eating like this, I would strongly consider incorporating it into your life. We have a question.
What are your thoughts on protein bars as a source of adding to your diet?
It's a good question. Somebody's asking me, what are my thoughts on protein bars as a way of adding it to your diet? I don't like protein bars because they're ultra processed. So whatever protein they're putting in there is some chemical they added, and they're usually produced in a high heat environment with different emulsifiers and preservatives. In a pinch, it's probably okay, but again, whole real foods that you cook yourself is vastly, vastly better. You could make your own protein bars too. There are some recipes out there that you could look up, but the ones that are designed to last in transit from the factory to the store and then to sit on the shelves for months to years before they're bought, those maybe avoid. Fiber, why do you need it? What is it? The technical definition is this: non-digestible carbohydrates and lignin that are intrinsic and intact in plants. So basically, this is stuff you eat that your body is unable to digest. Why would you want that? You're wondering to yourself. For a number of reasons. It makes you feel full because it's in your stomach, it's stretching, you get the stretch reflex, it's in your gut senses it, and you get satiety triggers, so you feel fuller. It's the more fiber you eat, the less calories you take in, and every study shows that. High fiber intake reduces calories by increasing satiety, decreasing hunger, and also just the bulk of the food is taken up by non-digestible things. So for instance, remember I told you don't drink orange juice, eat oranges? You get a third less calories from the same amount of oranges as orange juice because of all the fiber. You take longer to chew this food. Mastication actually is linked to activations of certain brain centers that induce satiety. So the longer you chew your food, the more full you'll feel, and fiber forces you to do that. Most importantly, you're feeding the gut. What do I mean? You're feeding the bacteria in your colon, particularly the large intestine, okay? By feeding the gut, they're producing neurotransmitters and little ketones that are feeding your brain and the rest of your body. If you don't feed the bacteria in your gut, you will never be healthy. We're mostly bacteria. There's more bacterial cells than human cells. It's basically, we're just a transport system for the bacteria. You have to feed the gut. And you can do it with insoluble and soluble fibers. You really need both. But you have to eat a lot of these non-digestible carbohydrates if you want to not have neuropathy or have better neuropathy, if there's such a thing.
Metabolism would slow down because you took too much fiber.
Somebody asked if the metabolism would slow down from taking too much fiber. Very few things actually change metabolism, the metabolic rate. Okay, so the short answer is no. Most people have the same metabolism no matter what. It's kind of a myth that your metabolism changes. There have been long-term anthropological studies showing this. That's a whole nother talk. In my weight loss talk, I got into that a little bit. But to truly change your metabolism, you would overproduce heat, and then you would basically cook yourself. So your body finally tunes your metabolism. What's probably happening is you're just eating less calories because of the volume of fiber. Slowing your metabolism, meaning that you would last longer on more food, I don't think that's really happening. Okay, micronutrients in the Mediterranean diet. Again, increased polyphenols. What's a polyphenol? It's just a molecule in a plant that is highly antioxidant and anti-inflammatory. You're going to have reduced diabetes and reduced obesity the more of these things you eat. Other names or other molecules are flavonoids, phenolic acids, stilbenes, lignans. There's a bunch of different phytochemicals, plant chemicals, that are massively important to human health. This is why I take a lot of antioxidants based on plants. So like tart cherry extract is literally water extracted, very old-fashioned methodology to extract the anthocyanins from the pigmented skin of the berry to give us that awesome antioxidant and anti-inflammatory molecule to promote health and wellness and reduce pain. The Mediterranean diet gives you all of these in a plate of beautiful, yummy food. But if you can't eat 9 servings of fruits and vegetables every day and you can't get all of these really high quality ingredients, your way to sort of make up for that deficit is to supplement with good antioxidants and anti-inflammatories. This is just showing you different foods and what they give you. So cloves, dried peppermint, star anise, filled with polyphenols. And then coffee, oranges, apples, all these things are filled with these phytochemicals. Olive oil has them, like we talked about. Beans, onions, filled with quercetin, a longevity molecule. So is apple. So that whole myth of an apple a day keeps the doctor away, very true. You're getting more quercetin. This is a very busy slide. We don't need to get into it, but the whole point of this is to show you why fruits and vegetables are so important. What treatments can you do besides diet? Okay. I send people to physical therapy for neuropathy, stiffness all the time. There are techniques like neurodynamics with nerve mobilizations. If you do this right now and you put your arm out and bend your wrist up, you may feel something in your arm, like a little bit of a sensation. And then if you put your ear towards the arm, it goes away. And when you put your ear away from the arm, it comes back. That's because you're stretching your nerve. You're mobilizing the nerve as the axon goes to your hand. That is nerve glides, nerve flossing. So your therapist should be well-versed in that. If they're not, you need a new therapist or a better order written. Thrust and non-thrust joint manipulation. This is very high velocity, low amplitude. This is physical therapy technique. This is not cracking your back and all that, okay? This is more gentle, focused, and precision. Myofascial releases will address all of those restrictions from the advanced glycation end products that are surrounding the nerves, particularly the length-dependent nerves, and will help all of your muscles and joints and connective tissues feel better because you're going to reduce the tension around the nerves. Sensory re-education and desensitization. There are very complicated connections between the brain and the peripheral nerves. And a lot of times the wiring gets messed up and rewired over time with chronic pain, chronic nerve dysfunction. So really good physical therapists know this and they know how to reverse that wiring and rewire it in a more normal way. And then of course, manual lymphatic drainage to get excess fluid out of the tissue so your electrolyte balance can be proper. So if you have a really good physical therapist and a doctor that knows how to use them, you can really treat a lot of this non-surgically without medication in conjunction with a good diet. Multiple layers of fascia. Here's a cross section of a leg, okay? Showing you all of the fascia. All of those lines in there is fascia engulfing certain muscles. The bone is a type of connective tissue. But what you're not seeing, you're seeing the fascia that like surrounds a muscle on the outside and holds it as one compartment. But there's also fibers going in all different planes, connecting every single cell together and every single nerve. Now, the main thick fascial lines, we've mapped these out and we know how to treat them. So I send people to PT a lot for the posterior back line, which connects the back of the skull all the way to the plantar fascia. One continuous line of thick fascia. And if you have a good physical therapist that can make that a little bit more flexible, a little bit more giving and maybe more functional, you can treat a whole bunch of problems. So physical therapy, the techniques we talked about, and fascial techniques are very important for nerve function and make neuropathy less detrimental. So I think of neuropathy as a connective tissue disorder. Anytime your nerves have become dysfunctional, you have to assume that all of the fascia and the muscle and everything else is equally as dysfunctional, and you're just manifesting in the nerves because that's what the brain can pick up. So the electrical signals from all of this messed up tissue, really the only thing we can feel is what our nerves are telling us. Therefore, neuropathy is focused on, but it's really the connective tissue all around them. So massage therapy works. Anything that you can do to improve the flexibility and the movement of the nerves is going to help. So one of the reasons I love physical therapy for these problems. Okay, medications. You're probably all wondering, some of you may be on some of these medications. It's going to be a quick course in why we pick what we pick and why they work or don't work. Pharmaceuticals. So we're treating either the positive or the negative symptoms. Positive symptoms are like intense pain, pain where you shouldn't have pain, excessive pain, okay, like actual pain. Negative symptoms is more like numbness, like the absence of something that you're supposed to normally feel, like absence of position sense, absence of balance, numbness. So we're trying to treat positive and negative. Most drugs are targeted to the positive symptoms, right? There are very few on-label FDA-approved drugs. So most of us are using drugs off-label. Conveniently, a lot of insurance companies will use that as a reason to not pay for things, okay? Just keep that in mind. The on-label FDA meds that have been approved for diabetic peripheral neuropathy are duloxetine, which is Cymbalta, pregabalin, which is Lyrica, tapentadol, which is Nucynta, and an 8% capsaicin patch. We also use anti-seizure meds, tricyclic antidepressants, selective norepinephrine reuptake inhibitors, norepinephrine reuptake inhibitors, opioids, sodium channel blockers. All of these are used all the time. I use them all the time. They're all off-label. Gabapentinoids. This is probably one of the most common. Some of you may be on gabapentin right now. It's a calcium channel blocker, so it's going to stop the release of the neurotransmitters at the synapse of a nerve, okay? It takes 30% of people to get 50% reduction. So this is when it gets squirrely with drugs. So you take gabapentin at a max dose, we can only expect about a third of our patients to get half of their pain relieved. To me, that's terrible, but this is the world we live in where pharma is king. So we really only expect 1 out of 3 to get any pain reduction, and if we're lucky, it's half of their pain. The target dose of gabapentin is 1,800 to 2,600 milligrams a day. I give people 300 really at the most. Some of my patients take 600. The side effects are why. Somnolence, sleepiness, gait issues, leg edema, dizziness, brain fog. So remember, it's not just tamping down the activity of the peripheral nerves causing pain, but it's doing the same thing in the brain. So gabapentinoids, very common. This is Neurontin or gabapentin. Lyrica, some people take up to 600 milligrams a day. Again, only 1/3 to 40% of people are going to get 50% relief at the max dose. Again, that's not a great track record. Same side effects as gabapentin, but I also see almost everybody on Lyrica gain weight, so I try to avoid it. Because to me, if part of your problem is obesity, why would you ever give somebody a drug that induces weight gain? Lyrica, of course, has more bioavailability and more plasma concentration. Therefore, it's brand name and still brand name. It's also controlled, by the way. It's very expensive, but it doesn't seem to matter clinically. So yes, it's more bioavailable, and yes, there's a higher plasma concentration when you take it, but it's 6 of one, half a dozen the other, gabapentin, Lyrica. What happens is people max out on GABA, or they say the GABA doesn't work, and then they switch or add Lyrica. Why? Because Lyrica's harder to write. You have to use your 2-factor authentication. It's a controlled substance. Only the doctor can write for it. It's only, you can do it once a month. I mean, it's a pain in the butt, and it's very expensive. But Lyrica has its role and is sometimes used. I write for gabapentin probably more often than any of these drugs I'm talking about because it's generic at this point. You can give it in a low dose, and you can wean off of it quickly if you're at a low dose, if it doesn't work or if your side effects are bad. Leg edema, I've seen once in a while, but I've actually seen leg edema with anti-inflammatories as well. Selective norepinephrine reuptake inhibitors. This is one of your FDA approved, along with the gabapentin. Cymbalta, that is on label up to 120 milligrams a day. The most doses in the literature are 40 milligrams to 60. It comes in 30s in my system. So I end up starting at 30 and going to 60. Some people I'll bump up to 90 a day. Cymbalta works well, and it also has the added benefit of helping with the mood disorders and the depression. Effexor, which is venlafaxine, Cymbalta is duloxetine. Effexor is off-label, usually 75 milligrams a day works. So the people that don't respond to Cymbalta, we try Effexor. And usually we're giving this in combination with anti-inflammatories and gabapentin. So we try the, I guess the lowest risk meds first, and then either switch or add the higher risk meds as things don't work. The tricyclic antidepressants, that's sort of an older category of antidepressants, but they still work very well for nerve pain. Amitriptyline, nortriptyline. There are side effects like dry mouth, dry eyes, things like that. It also inhibits the reuptake of norepinephrine and serotonin in the brain, which means you have more of this floating around to work for you. And then it inhibits some other receptors. Again, with full dosing, we really only expect a 25% reduction in pain. So this is why a lot of your patients are on cocktails. I'm not a lot of your patients. This is why a lot of you guys are on cocktails from us. So if gabapentin, we're only expected to get 50% pain relief in a third of people, obviously we're going to have to add something else. Let's say we add Cymbalta. Maybe that doesn't work. Well, now we're going to have to add a tricyclic. Well, that's probably not going to work. So what do we add next? This is when you get people with polypharmacy. They've got like 6 meds on their list just for their pain. And we know that compliance goes down every pill you add. So who's really even taking all of this? Probably not a lot of them. And that's actually been studied. I think it's 15 to 20% are fully compliant. This is a problem. This is why I'm a big fan of natural ways to treat these things. All right, so we're up to the tricyclics. What else do we have? Tramadol. So it's sort of a narcotic, sort of not a narcotic. It does agonize the mu receptors, which is the same way that morphine and all drugs work, but it's also a selective norepinephrine reuptake inhibitor. It'll increase levels of serotonin, so you're at risk of serotonin syndrome on tramadol. So if you have another, like you're taking an SSRI like Zoloft or something, just be mindful and be careful adding tramadol. Tramadol is pretty common medication. It's the lowest grade or the weakest narcotic we can give people, so we kind of go to that one first. Tapentadol, FDA approved for this problem. That's your Nucynta. Up to 600 milligrams a day is okay, theoretically. Opioids work. They definitely block the pain, but they have tremendous amounts of side effects on quality of life, and they stop working and they get addictive and you have to escalate. We try to always avoid that. Topiramate is another one. Phenytoin or phenytoin, however you say it, a seizure medicine, sodium channel blocker, works great for diabetic neuropathy and fibromyalgia in some cases. Usually added if all else has failed or if you need yet another addition to your cocktail. Lamotrigine, another anti-seizure medication that works. Topiramate is a sodium channel voltage blocker. Common side effect of topiramate is weight loss. So actually, for my obese patients, sometimes we prescribe topiramate to help them lose weight. In combination with phentermine, which is Adipex, that drug is called Casimia. You may have seen commercials for that in the past. So the problem with pharmaceuticals, no one person usually responds to just one of these drugs to treat their neuropathy and their neuropathic pain. About a third will get 50% reduction in pain with one drug. Therefore, we must use polypharmacy. So almost half of people have to have combination therapy. And then basically you just play the try it, don't try it, wean off, wean on. You just keep working at it till you get the right cocktail for that patient. This is why alternatives are necessary, like physical therapy, but also acupuncture, neuromodulation, diet, lifestyle, mind-body treatments like meditation, cognitive behavioral therapy, things like that. Yoga, Tai Chi, Qigong, all of these are being looked at as alternative ways to help with diabetic peripheral neuropathy. And of course, surgery. So what are your surgical options? I do all of these surgeries and I do them often. Releasing trapped or compressed nerves really seems to help nerve function improve. And there are multiple studies in the literature that show that if you release a compressed nerve, you can actually help the neuropathy get better, even though technically there's no cure for neuropathy, right? And then there's another procedure called a reset neurectomy, where we actually remove the damaged and painful part of a nerve, literally excise it out, and then put in allograft, a cadaver that's been treated to be just a scaffold, connected to the two human nerve endings or live person nerve endings, and then eventually the body propagates healing through that scaffold. That's called a reset neurectomy. It's a way to treat chronic neuropathic pain of certain named nerves. So we've got entrapment reliefs, reset neurectomies. We can also open up the skin around a nerve and remove fat and scar from within the nerve. You have to use a microscope to do that. We do that a lot. You can do nerve repairs. You can do nerve grafts. You can do nerve transfers. There's a bunch of surgical ways to help manage these problems. One of the most effective ways to manage chronic pain from nerves is neuromodulation, highly effective. You've probably heard of spinal cord stimulation, which is effective in a lot of cases, but not all. I do a lot of peripheral nerve stimulators. So we actually put electrodes on a peripheral nerve. We've done it for the nerve to the wrist, the ulnar nerve. You can do it for carpal tunnel. You can do it for chronic knee pain. There are named nerves that cause knee pain. You can do it for leg pain that acts like radiculopathy, the perineal nerve. You can do it for tibial nerve. So for a lot of people with diabetic neuropathy or named nerve issues that have failed other treatments, this is an excellent technique. All that you're doing is using what's called the gate control theory of pain. So when you turn this thing on, you're just sending a little voltage that stimulates the larger fiber, the myelinated nerves, sends signals to the brain, and that overpowers and confuses the brain, and the brain no longer feels the input from the unmyelinated C fibers. So you're basically using the body's own methods of processing electrons and nerve current against the pain. You're tricking the brain. So by stimulating the nerve, you feel less pain. It's minimally invasive, extremely safe, really effective. And you don't have to take drugs. And it's a permanent solution, generally speaking. This is a spinal cord stimulator. I put this picture on the left. You have to go through this trial period to gain insurance approval where you have this thing actually sticking out of your body into the canal. Sort of gives me the heebie-jeebies, but this is the process we're forced to go through. And then you implant this thing into the spinal cord. It works the same way. It's sending a low voltage current and it's confusing the nerve roots. Your brain doesn't get the pain signals. That's all that it's doing. So what supplements, you're probably wondering? A lot of people that watch these sorts of videos are interested in natural medicine. We kind of went through them, but I'm just going to quickly say vitamin D3, hugely important. The B vitamins, very important. Omega-3, particularly DHA and EPA. And I think getting it that way is better than ALA, like in flax and things like that, because your body is inefficient at converting ALA to what you really need, which is the DHA and the EPA. Alpha lipoic acid, we talked about that. We have it as a single molecule. N-acetylcysteine, that's in our nervous system multi, combined with omega-3s for you for convenience. Glutathione, that's in our liver 15-day detox. So glutathione is your number one detoxifying element in the body. So it's your natural antioxidant. We probably just don't make enough of it. So a lot of people will go to IV clinics. We have an IV clinic and we do this for people, but it's expensive. It takes time, and you can get an infusion of glutathione or you could take it orally. So about once a quarter, I'll do the liver 15-day detox and get a lot of glutathione that way. Palmitoyl ethanolamide, we already talked about that. That's in the same family as cannabinoids, okay? NMN, which refills your NAD, which is your energetics that are depleted when you have too much sugar in your bloodstream, and also goes down with age. And then believe it or not, different little substances out of mushrooms have been shown to help with nerve regeneration, brain health in particular, one of which is lion's mane. We put that in our focus supplement and also, in our energy supplement. And then there are other mushroom-derived beta-glycans or molecules from mushrooms like cordyceps or reishi that are in those alternative supplement mechanisms or ways to get these things into your body. Obviously, it's really hard to go find lion's mane in the hills or at the grocery store, so I supplement. So these are some supplements that you can take every day with very low, if any, risks that will help your nerves to heal themselves, repair themselves, and prevent worsening of any given level of neuropathy. Some of these are used as first-tier treatments in other countries, particularly the ALA and the PEA. So don't discount the supplements. None of us, with rare exception, unless you're uber wealthy and you have a private chef in your own garden, are getting a true traditional Mediterranean diet. We're certainly not walking as much as we should and socially interacting and work with purpose and meaning and all that. All of that's part of the Mediterranean lifestyle. So the way around that, the shortcut is supplementing. That's why I'm a huge fan. That's why I started the Well Theory. I became such a believer for myself and my family that I developed a line of my own stuff that's all third-party tested, all made in America, and the APIs are heavily scrutinized as well, so that I would have a safe source, that I knew what was in it, and was designed to treat these particular problems of anti-inflammatory, antioxidant, so I could reduce inflammation, reduce oxidative stress, and importantly, reduce advanced glycation end product formation. So hopefully this gave you an understanding of how we think about neuropathy, how we diagnose it, all of our treatment options, why you're on any given drug, like why was that picked? Hopefully it gave you a basic understanding of that. And then things you can do for yourself, particularly diet, mostly avoiding ultra-processed foods and fast food, but then bringing in all of these good foods to your life. So I'm going to take a couple questions now. 1,000. Yeah, the question was how much lion's mane per day. There's no true consensus on this. In our supplement, we have 1,000 milligrams. Some people will take more, some will take less. Obviously, the problem with the world is nobody funds really good studies on natural medicine because the big drug companies can't get a patent on it, with rare exception. There are a lot of patent trolls out there now trying to patent every supplement under the sun. But in general, we don't have a lot of good studies to give you a really good guide. Also, every patient's different. But the generally accepted levels that are known to cause no significant adverse effect and probably have a beneficial effect is about 1,000 milligrams. Those are all of my supplements. I kind of picked those levels where we know it works, or the basic science studies show that it should work at that level for any given functionality of the mitochondria or whatever, and the adverse event profile is diminished or negligible.
4,000 milligrams of mushroom extract.
Yeah, so the energy all told will give you about 4,000 of different mushroom extracts. So that gives you what's called the entourage effect, where you get different substances from different vegetable, or in this case, fungus products. So remember, technically a mushroom's a fungus in most cases. So you're getting the micronutrients from different species, which gives you that variety you need. Remember, I told you the Mediterranean diet is 9 different fruits and vegetables every day. So it's important to change up the supplement sourcing too, to get those different entourage effects. Yeah, so if you have questions about this or need guidance, I see people for this a lot in my private clinic at Warner Orthopedics and Wellness. That's in Baton Rouge. Or this is a free webinar. I'm not asking you to do anything. You don't have to listen to annoying commercials. I'm not reading you commercials. I'm just telling you what I know and trying to educate you. Obviously, I'm going to tell you about my supplements because I believe in them and take them, and this is a passion of mine. But go on my website. I've done a bunch of these webinars on a variety of different topics. The more you can learn, the more you'll be empowered to take care of yourselves. All right, everybody go enjoy your Sunday in May.